Good evening and welcome to Black Doctor Speak. I am Ellis Dean, a senior project manager with blackdoctor.org. And tonight we've got a special show. We got a little different format because um, we're really talking about something that's really troubling to all of us. And so we asked Dr. Glenda Newell Harris to come back and speak with us, but I'm going to hand it off to our man of the hour, Dr. Lenore. How are you doing this evening?
I'm either esteemed, the man of the hour, or the main man. But anyway, thank you so much for the opportunity. It's a very serious issue that we're going to discuss today. We've been, through the years, we have been actively advocating for African Americans to take charge of their own health because of the way the healthcare system treats them. There's no better example than what happened to Dr. Susan Moore. Many of you may or may not know about Dr. Moore. She was a family practice doctor in Indiana. She got COVID and gradually, with a series of symptoms, she was treated in the system in the way so many of us are treated. And I say us because we're going to share some of our own stories with you about how it can happen. But we established the African American Wellness Project because we want you to understand what can happen and to develop some skills and skill sets that will prevent this from happening to you. And so we invited Dr. Glenda Newell Harris, who is a internist who has written a book called Focus on Your Health, a tremendous book on advocacy. And we'll talk about how that interplays into what we are talking about today. But first, let's look at the video that Dr. Moore made of what happened to her in the intensive care, and unfortunately, last Sunday, she died of coronavirus. So can we go ahead and start that, Ellis?
Birthday here. Are you north? Yesterday, Dr. Bannock, BANNEC, wanted to send me home. At that time, I'd only received 2 treatments of the remdesivir. He said, "Oh, you don't need it. You're not even short of breath." I said, "Yes, I am." Then he went on to say, "You don't qualify." Most of it because I've gotten 2 treatments. Then he further stated, "You should go home right now." And I don't feel comfortable giving you any more narcotics. I was in so much pain from my neck. My neck hurt so bad. I was crushed. You made me feel like I was a drug addict. And you know I was a physician. I don't take narcotics. I was hurting. So I spoke to patient advocate who left me wanting. There's not much I can do. So I started asking, send me to another hospital where they can treat me. And if they're not going to treat me here properly, send me to another hospital. Well, next thing I know, I'm getting a stat CT of my neck with and without contrast. The CT went down a little bit into my lungs, and you could see new pulmonary infiltrates, new lymphadenopathy all throughout my neck. And all of a sudden, yes, we'll treat your pain. You have to show proof that you have something wrong with you in order for you to get the medicine. I put forward and I maintain was white, I wouldn't have to go through that. And that man never came back and apologized. This Dr. Bannock guy. And then today now, so let's be getting narcotics, right? They came in 9 o'clock. I've been in pain since 7. And when they came in, very, very sympathetic. Yeah, we will get you pain medicine. I don't want to give you IV narcotics. How about PO? Fine. I just want my pain to end. So then he says, well, what pain medicine? I said, I don't know. I don't take them on a regular basis. I don't even write for them. All I know is that I'm in intense pain, and morphine worked. Okay, well, we'll give you Percocet. Okay. I don't know nothing about it. I don't think I've ever had it. It was another 2.5 hours before I got the pain medicine. The nurse came in, but the first thing I said to that nurse was, why did I have to wait for so long? The nurse snapped back. Well, you're not my only patient. I have 5 other patients, you know. I said, I have been in pain since 7 a.m., you know. Well, I can't be in here every 5 minutes. I said, no, you were in here once in 4 hours. What? I was in here an hour and a half to 2 hours ago. That was once, since your shift started at 7. Well, I had other people, and I had to take the shift change. We had to give a report. I'm a patient. Are you going to take care of me or not? And he went in. Now, that is not how you treat patients. Period. So, I don't trust this hospital, and I'm asking to be transferred. These people wanted to send me home with new pulmonary infiltrates and all kind of lymphadenopathy in my neck. The other thing that that white Dr. Bannock said was that if I stayed, that he would send me home Saturday at 10 p.m. in the dark. Who does that? On a week, who does that? And that nurse was telling me, oh, I was marching in Black Lives Matter. I told him, no, I don't believe none of that. Not one bit. Not one iota. You wouldn't even know how to march. I can't even spell it. This is how black people get killed. When you send them home and they don't know how to fight for themselves. I had to talk to somebody, maybe the media, somebody, to let people know how I'm being treated up in this place. And he gladly told me, I know you're a doctor. But he didn't want the black doctor to have no medicine, nothing. And then had the nerve to say it's because of him, the nurse, that I got the medicine. Really? Because of you? No. How about because I had that stat CT in my neck, where it showed all of that lymphadenopathy and infiltrates? Yeah, you didn't know about that? You didn't get that in report? That's what I said. Mm-hmm. Mm-hmm. To being black up in here, this is what happens.
Yeah, let's just get right to it, Linda. Our doctor knew. Would she have been treated like that if she was a white doctor?
So this Dr. Lenore is unfortunately what goes on too often. What is really sad about this situation is that this is someone that knows the system, knows how it works, knows how she is supposed to be treated. She does it every day for a living. This is how she makes her living. And the sad part about all of this is that most of the time when this goes on, it goes on, and those who are providing the care are completely unaware of the appearance of lack of sensitivity, the dismissiveness, as they were, of this person. I also read something about this before coming on tonight, and I understand that the CEO of the hospital identified her as being intimidating to the nurses, which again is something else that we as African American women often are accused of. If we speak up and ask questions, we are intimidating and confrontational. When others that don't look like us raise similar questions, then they are just being proactive and preventive for themselves. So this is unfortunately what goes on all too often. I am so saddened to see this happen. I could be in that bed. I could be that person right there in that bed. And the other thing about this that everybody needs to understand, it doesn't matter what kind of health insurance you have. You can work for, I won't call the names because they're not paying for the advertisements here. But you could work for any industry and have what you consider 5-star health insurance. But when you're in that bed, you're a Black woman. And that's how you're looked at.
Yeah, that's why we call this Black Doctor Speak, because we're not confined by institutional issues so that we can't speak for this or that. This is embarrassing to the hospital, plain and simple. When I first started, and I'll share my story first, unlike the process I organized. When I first started Black Doctors, the African American Wellness Project, I invited 22 of the most important African Americans in the Bay Area. Congresswoman Lee, 2 supervisors, several hospital administrators. I asked them, I said, have you ever been treated in the healthcare system as if you didn't exist or if you didn't have any worth? We weren't 3 people into that before somebody was crying. One gentleman who's still a politician here, his father had prostate cancer, and he'd go back and forth to the hospital. One woman who was in charge of all of the diversity programs for health in San Francisco went to the hospital 3 times, diagnosed 2 times with hysteria, and the 3rd time with a stroke. Another person, the doctor who was with us, who was still in practice, she said to me, she says, when I go in the hospital, I am invisible. Even the doctors to whom I send a lot of patients, they don't see me. They don't walk right by me. And then one other situation where we had some diversity training for a large HMO here in the Bay Area, in which the convener, who was very scientific and forceful, went through several instances. The white physicians got so upset. It's not me. It's not me. I treat Maddie just like I treat Mrs. Golden. It's that kind of thing. They said it isn't me. And I just think that this is kind of this is the way every one of you who are listening to us will be treated at some point in the healthcare system simply because you're Black. Ellis?
I think as in some of the people that were talking in the chat room, I'm going to give some more background on Dr. Moore. Dr. Moore she immigrated from, I believe, from the Bahamas or Jamaica. Here, she was a civil engineer with 3M, and then decided to go to medical school. Went to the University of Michigan Medical School and was practicing as a family physician there in Indiana. So this wasn't a woman that didn't know what she was supposed to be doing and didn't, that was in there speaking out of tongue. She was really telling, and she's not, as a physician, she's not going to tell the doctor any symptoms that she's experiencing just out of off the top of her head. She knew exactly, as you can tell, even from watching her videos, she knew exactly what was going on and what she needed, how she needed to be treated. And when it didn't happen and it looked like it was getting continuously worse, it was like they were almost pushing back as she continued to speak up for herself. It was like it almost felt intentional that they were going to try to keep her in her place. And that's the part that was most disturbing about all of this, is that when you're looking at somebody that is as accomplished and as determined as she was, it didn't matter. And to your point, Dr. Lenore, it did not matter who she was when she was in that bed. It was what those doctors and what those nurses decided to give her and how to treat her. And it ended up, she was diagnosed on November 29th with COVID, and she died on December 20th.
Yeah, I mean, it's really, and this is not unusual for even those of us professionals. If you think that your degrees and the fact that you're important to, Glaxo, or you're important to the Federal Reserve, is going to shield you from this kind of interactions in the healthcare system, you're wrong. I mean,
Absolutely.
this all of the time.
Absolutely.
And as a doctor, I sit around. Sometimes it's not even my patient, but I have to stop the conversation, or I have to intercede for the patient, or I have to do something because it's so flagrant. And I'm in the most liberal part of California. You can see it. I'm going to plug in my computer. Talk among yourselves.
You when you're sick, you shouldn't have to, when you're in your own bed in the hospital, you shouldn't have to beg the doctor for a test. You
Right.
shouldn't have to beg for a scan. You shouldn't have to beg for medication. Another thing about Dr. Moore that I read is that Dr. Moore also had a condition called sarcoidosis. And I don't know if there are a lot of people that know much about that disease, but it is in the family of diseases like lupus. It's sort of like your body turns on itself, and many parts of your body are infiltrated with this tissue, and it impacts your lungs and impacts a lot of things, your brain. But she had sarcoidosis. And that's sort of like, we hear a lot about patients with asthma and COPD developing COVID pneumonia. So here was a patient that had sarcoidosis, very likely that she had some lung involvement. So she had that already as a compromise. So for her to be sitting there in that bed with nasal cannulas in her nose, that's what we call those tubes that are giving her oxygen. And for her to be told by the doctor that she's, quote, not that short of breath. Short of breath is a subjective feeling. So how can a doctor tell a patient that she's not that short of breath? In fact, if she was not short of breath, why did they have oxygen on her? Honestly. And then the other notion of, pain. I can't give you any more pain medication. Why? Who are they saving it for? Just like for remdesivir. She got 2 days of remdesivir. The literature that I've read is it's supposed to be 5 days of remdesivir. So why does she get 2 days of remdesivir? And then is it time to then barter and bargain as to whether you're going to get more? We have some people in this country that were given remdesivir and nobody knows whether they had oxygen problems or not. We just turned on the television one day. We saw somebody walking out of a big house in Washington, D.C., and that person moved from the house they were in into a hospital and got all the remdesivir, all the monoclonal antibodies, and all the dexamethasone that was necessary.
We can get real. If you go, just not to stop you, but stopped you. But if you want to see what your worth is, go into an emergency room with pain as a Black person. The immediate assumption is that you're going to be a drug addict, or you're going to be a pain person, or that somehow, like when my professor at the University of Texas said that morphine was a depressant for most people, but it excited Black people and horses. That's the kind of mentality you're going to face in the emergency room. If you're Black and in pain, and if you've been there more than one time, which may indicate more serious disease, they're going to assume that you are almost classically that you are a person who has a chronic pain problem.
Yeah.
And studies demonstrate that many doctors feel we can handle pain better, or that we are in places complaining of pain because we have a drug associated problem. And so this is not uncommon. I mean, and we could go on and talk about some of the instances of how that happens, but I want Black people to know, and people of color, that if you're not on the case, or somebody's not on the case for you, that what happened to Dr. Moore, a doctor in that community, that's almost unheard of.
Right.
For me, in that community can be treated like that. Believe me, I don't care, you're the vice president of this or that, you're the only brother on the floor in some company. When you don't have your credentials and you go into a hospital, you need to understand, and we need to start talking a bit about how you avoid this kind of circumstance.
So I guess there was a question. I'm sorry for interrupting. There was a question in the chat room that said they were talking about COVID, and if you feel like you haven't been treated, like in this case, you haven't been treated properly when you present with COVID and COVID-like symptoms, what recourse do you have as a patient?
That's an excellent question. I have a family member who went to the emergency room during the holidays, an attorney by profession, had respiratory problems. They gave him doxycycline and sent him home. He had an O2, a pulse oximeter with him. And they gave him a breathing treatment and some doxycycline and sent him home. And then 2 days later, his oxygen continues to drop. And he took himself back to the emergency room. Fortunately for him, his mother is a physician, but he sat around the hospital for 10 to 12 hours before they would consider putting him on remdesivir. In that particular situation, it was a doctor that had to call to kind of make the demand. But my question was, what about the doctors that were working in the hospital? What kind of, unfortunately, what it seems like to me is it's a bit arbitrary. So what can a patient do? So here's the thing. During these days of COVID, you can't even bring an advocate with you into the hospital.
Right.
So you really have to kind of be prepared on your own. So I say to everyone, go out and buy yourself a pulse oximeter. Now, if you really want to be on top of things, on December 17th, the New England Journal of Medicine just put out an article saying that African Americans show a lower number on their oxygen saturation. So when our number is, say, 97, according to their study, we really are lower than that. So I say to you, get yourself something that's objective for the hospital to work with. Check your own temperature. Don't go in and say, oh, I feel hot. Check your own temperature. Get your own pulse oximeter. You can buy one off of any one of these, places that drops it off in your home for $35 or $40. Come in with some objective information and then pray, because you can't bring an advocate with you, but your advocates can call. Your advocates can call and ask questions of the nurses, and that's what needs to happen. And that's what happened here with this case with Dr. Moore. My understanding is she did raise questions, and of course, then she got labeled as being difficult, a difficult patient.
Right. Yeah, and don't think, I mean, this is Black Doctor Speaks, I'm gonna be straight up on it. Don't think that because you're lying there being cooperative, that's really gonna make any difference. You may just be the last one mentioned. I mean, I always say the same thing, and I've said it every program. You get as mad as you get it when somebody cuts in front of you. In the same way, you wouldn't have this problem. Don't be afraid to demand services, because especially when these in these life and death situations. The other thing that bothers me about this is the extrapolation to how the vaccine is going to roll out. Starting to get a little concerned about this vaccine rollout. I mean, when we first heard about it, our challenge as doctors was to talk to African Americans about the value of vaccines, and I think we've done a lot of that, and we've been trying to be transparent and truthful about it. And I plan to get the vaccine. But what I'm hearing now is, the states decide who gets the vaccine.
Yep.
We're here in the Bay Area, and those of us who see patients, we haven't seen hide nor hair of a vaccine yet.
Wow.
So consequently, I'm thinking that we're going to have to be more aggressive about working with states and people who are making decisions about how to give out the vaccine. I think one of the things that Dr. Newell Harris said is that you have written a book. The book is called Focus on Your Health. Everyone should own this book because this is a book, if we talk about how to avoid the situations that Dr. Moore was in, she did everything to avoid them. But she was at the mercy of the system. But your control of the healthcare system starts way before you go to the hospital, doesn't it, Dr. Harris?
It absolutely does. And, as I said earlier in the program, it doesn't matter what kind of health insurance you have. So you show up at the hospital, you need to come in with your facts, your details. And, as Dr. Moore did, I have to say to you, and this has happened to me with some patients as well, if you're not getting good care at Hospital X, then she transferred. And the reports are that she got much better care. At least her perception of it was much better care. But honestly, I just have to say, when we talk about this business of implicit bias, I mean, how is it that you really can show sensitivity and caring and warmness when you really already have determined that this is a sector or group, a kind of person or thing that you just don't relate to? If I don't like people with green hair, and I have 2 patients to go see, one has green hair, one has red hair, I need to check myself when I'm on my way into the room with the green-haired person. That person needs to get the same care as long as their stats are the same. So I say in our book, Focus on Your Best Health, you need to be knowledgeable about your health. You need to be knowledgeable about your insurance. You need to learn how to speak up for yourself. We talk about being agreeably aggressive with the providers and with the nursing staff. If you feel that you have not gotten what you are supposed to get, you need to speak up about it. There should be no fear. And if you feel that the care is not what it's supposed to be, ask for the nursing supervisor. Ask for the vice president of customer relations. I want to go on for a minute, Dr. Lenore, and talk a little bit about this diversity training.
I will come. I would just use an old religious expression: "Come to us in your own way."
Okay. Well, when you find yourself in a situation like this, and you are helpless. This is the other piece about it. You're sick. You how do you advocate for yourself when you're sick? So you're there, and then a story like this breaks, and the very next thing we hear is, "Oh, we're going to put everybody through diversity training." So, diversity training is not a one and done, and that's what I see happen all the time. "Oh, we're going to put people through a diversity training." In the state of California, we have to go through, I believe I work in multiple states, but there's certain training you have to do every year. It's HIPAA, it's code of ethics. But I say diversity training needs to be every day ongoing. There needs to be a trust and verify around this. How many patients are coming into hospitals in your community that are getting 3 days of remdesivir versus 5 days of remdesivir? Maybe the hospitals need to take a look at that. What kind of diversity? Do you have a diversity person at your hospital that basically deals with Kwanzaa, Hanukkah, and February? Or is this something that is ongoing every month, every day, all day? Because if you don't call people out on it, then it's like, "Oh, I don't have any biases. I love everybody." But that's really not what's going on in that exam room with that patient. And remember, I can handle not being dealt with appropriately in the grocery line, because if grocery line number 1 doesn't take me, eventually 2 will take me if I'm in a longer line. And I'm upright, I'm mobile, I can talk. But imagine you're in a hospital, you're sick, you don't feel well. You've come there for help. And then you have to get enough chutzpah to be able to convince and cross-examine and interrogate people that you are paying to take care of you in order for you to not end up dead in bed.
Yeah, I think this case has impassioned Black doctors more than anything else, because this is something that reflects on all of us. One of the things that I didn't hear Dr. Moore say is she didn't really have a primary care doctor. How important is it for you to have a primary care doctor, and how do you get one that you can kind of depend on?
Dr. Lenore, a primary care doctor is really, she is the driver of the bus. You must have a primary care provider. And I think the best way to find a primary care doctor is to ask your friends. If your friends have a primary care doctor that they like, then chances are you're going to like that person too. There are many different ways that people look for doctors. They go online, they read Yelp, they find out from their plan who's covered under their plan. But quite honestly, since I've been in practice, I mean, when I first came out, I was told, well, you're doing well when other doctors are referring to you. But when other patients are referring to you, that's the best way to get a primary care doctor. And you need to have a relationship with that primary care doctor. What does that mean? Well, first of all, you need to keep your appointments. When you're feeling well, you need to still go to the doctor.
Yeah.
Oh, I'm okay today, so I can just postpone that appointment. I don't need to be there. The doctor needs to see you when you're feeling good and when you're healthy. Because when you come in and you are sick, then they have a point of reference to say, well, that's not Glenda. That's not the way she acts when I know this person. You not only have your family advocating for you, you have your primary care doctor advocating with the hospitalist for you. So you need to establish that relationship, keep that appointment, the follow-ups. When you're well, don't just see the doctor when you're sick. But a primary care doctor is one that can intercept and intercede and be an advocate for you as well.
You need to check out the hospitals in your area. So that, some of the time, there have been times when I've seen patients select hospitals which were a death sentence, when you went in with certain kinds of problems. Let's be real about it. So yeah. if you're in your community, you need to check out the hospitals in your community. And when you have a problem, you need to head toward those hospitals.
Absolutely.
Could I add one thing just on the patient side? And that is, make sure you're doing what you need to do when you're not seeing your doctor or when you're not in the hospital to keep your health at its optimal level. And that means eating right. That means exercising. That means if you have some sort of medication regimen, or if you have a treatment plan, that you're following it as closely as possible to avoid having to present to the emergency room and put yourself in the hands of biased doctors or nurses. Because when you get to the point where you are not taking care of yourself and you're so sick that you have to go to the emergency room, you are placing your life, literally your life, in the hands of an emergency room physician and nurses, and they may or may not care about how you're feeling or what you're going through. And so therefore, as a patient, on the patient side, we've got to do what we need to do to make sure that our health remains as optimal as possible, and go see your primary care physician and get your baseline so they know, so that way you don't have to present to the emergency room anytime soon.
Now that's a very good point. And I don't want to, I think that's probably the most important point made here. But I do want people to understand all hospitals are not created equally. And you need to look around and look up the reviews and look to see how they treat your particular kind of problem before you just select one at random. Dr. Null, talk to us about advocacy. What does that mean? Why is that important? And how might that have changed the dynamic here?
So advocacy is critical, I think, in the healthcare setting. And quite frankly, I'm dismayed and shocked that it's not really caught on. No one has yet determined that they can put a price tag on that. But every single person needs to be an advocate. So you might say, well, tell me what that's like. So if any of you that are listening to us tonight have children, you have been an advocate for your children. When you take your children to the doctor, you have advocated for them. You have explained the problem to the doctor, and you've spoken up for them when they were young, when they're babies and they couldn't articulate for themselves. If any of you are dealing with elderly parents, you know, when the prescriptions don't get refilled, or mom or dad has some different kind of, they're not as coherent as they used to be. You call and you make requests on behalf of your parents. Well, there's no difference about doing that for yourself. Fortunately for Dr. Moore, she was alert and she was able to be able to articulate for herself and advocate for herself and ask questions. But you also see how that was criticized as being intimidating to the nurses. I don't quite understand how a nurse would be intimidated by a sick patient who happened to be a doctor. That's kind of amazing to me. But nevertheless, in this particular
case, code, Doc. That's code.
It is code.
Code. That's code. That's
code.
Like the word Doug has replaced the N word. It's code. It's all code. And so intimidation is so subjective. That's individually defined, and they can just say, well, she was intimidated, and you can walk away. But that's code, just so they can't say race or ethnicity, because then that becomes a deeper matter. Would you just say, I was intimidated? How are you intimidated? You're a nurse. You're on the job. You're doing your job, which is patient care. You shouldn't be intimidated by anyone. You could be frustrated by someone, by a patient. I've been frustrated by patients, but you cannot be intimidated by them. You're the professional.
Absolutely. Absolutely. They also use the term with this patient, with Dr. Moore, they call her complex. That's another code word. I do believe complex. So back to the question, Dr. Lenore, and that is advocacy. So we talk in our book about communicate, navigate, and advocate. Yeah. There are three things that we feel that you need to be able to do in order to advocate. First, you need to be able to communicate. That means that you need to be able to come in and say, I have this problem, I've got this temperature, I've got this blood pressure. They got all the tools out there now for you. You can pretty much almost take care of yourself. You can take your own blood pressure, your own pulse, your own O2 sat. So you have to have the knowledge and the ability to be able to articulate your situation. Then navigate. As Dr. Lenore also pointed out, you got to be able to know where to go. If you've got heart disease, you don't show up at a hospital that doesn't have a cardiac unit. You've got to be able to know how to navigate to go to where they are able to be able to, and that means you have to do your research in advance. And then advocate. If you can communicate and then you can navigate, then you can advocate for that situation. So you then go in and you do ask questions. There is nothing wrong with asking, why is my mother, my loved one, my auntie getting that bottle of fluid that's yellow up there? Why did it run in today over 2 hours when yesterday it ran in over 10 hours? What's going on with that? It's
one of the classics is, why are these bells going off and nobody's coming in here? I mean, I've seen that with my own patients, and I've definitely seen it in other sets of circumstances. But you can't just pick anybody as your advocate, can you?
No, you can't. There are many different types of advocates. We talk in our book about peer advocacy and professional advocacy. So a professional advocate would be a nurse, a doctor. That's someone that's very knowledgeable. But, I have to say this to you. When you go in, I say this to my friends all the time that I talk to. When they call and they have a complaint, I just tell them to get a piece of paper and pencil and start writing these things down. Because when you begin to use the same jargon with the doctor, you use it back to them as a layperson. They know somebody is watching over that situation. And I'm going to tell you, the care changes when that happens. I'm sorry to admit it. Yes, I'm in the profession. I love my brothers and sisters, black, white, purple, and green, practicing medicine. But some people just don't like the idea of somebody watching out and looking out. That's a professional advocate. But you can also have a peer advocate. Your husband, your adult children can be advocates for you. The other piece about this advocacy is you don't have to know medicine. You just have to use common sense. You know your mother. If your mother can't answer questions clearly with you today in the hospital, and when she came in last night, that is advocating. What's going on with my mother? You ask the nurse, you ask the doctor, raise the questions. So being an advocate is speaking up and speaking out, asking questions, trying to get clear answers. And that even goes to when it's time to go home. You notice Dr. Moore talks about send me home. You notice she said, and they want to send me home at 10 o'clock at night. It's dark. That's
Right.
another thing. When you send somebody home, who's going to be there? Who's going to be there to help when you go home? And who's going to likely be there at 10 o'clock at night? I have no knowledge as to why anybody would send anybody home at 10 o'clock at night. Most hospital discharges are mid-morning. But you have to advocate. And then you have to say, well, you know what? Mom's going home to an empty house. You can't send her there at 10 o'clock at night. You have to speak up and advocate and say, there should be no shame in that. That's another problem that I think some of us have, is that we feel that somehow we've got to take what information is given to us and we have to accept it and honor it. And if for some reason it doesn't work for us, we're ashamed to say, well, nobody's going to be home. Well, everybody's working. You've got a job. Of course, now everybody's working remotely. That's a blessing if you've got one and you can work it during this pandemic. But the bottom line is that if you find yourself sick, you better be calling your church member, your neighbor, your daughter, your son. You don't go through that situation by yourself. You need to call someone.
And especially if you've got a complex problem, like you've got uncontrolled diabetes, or you've got bad asthma, or you've got symptoms that linger on. You really need to take, especially for your grandparents. I'm a grandparent. I can certainly take my granddaughter in with me. She'd have a lot of questions. But you need to go in with your parents, your relatives, or your friends or your cousins who are older with complex chronic diseases. Because I can guarantee you, they're not going to really get any explanation, and what they do get, they're not going to understand. So when I was an intern at Los Angeles County, we put a booth up outside the hospital, and we asked patients what medicines they got and why. And it was embarrassing, so embarrassing. Hospital made us take the booth down. So you really do need to. It's something you say, this is who I want to be here with me. She's so and so, and she understands things a little differently, and I want to ask some questions. The other thing is that if you've got questions, write them down before you go into the visit. Because the visits go so quickly now that one of the other reasons we established the African American Wellness Project, and we're so pleased to be associated with blackdoctor.org, is that doctors do not have time to give you information about much more than what's happening at that particular visit. They're not going to give you information about early detection, disease prevention. They're really not going to explain to you most of the time exactly what the details of your illness are. And sometimes they don't tell you what the plan is. And so consequently, I think those are things that you need to come out of a visit with. And the only way that can happen is for you to be organized. When you come in there, when I come in and somebody pulls out a piece of paper, I sit up, pay a little bit more attention, because I know this is someone who's going to require a lot more time and a lot more investment of my time. And I think that that's so important and so critically important now. Other things in your book about navigation.
Yes. I was just thinking, Dr. Lenore, from the standpoint of navigation, actually, I'm going to pop this in right here. And that is making certain that when you hit the hospital, that you notify them in writing who they can talk to about your care.
Yes.
That's another piece of kind of navigation of advocacy, I'm going to say, because they love to be able to say, I can't talk to you because I haven't gotten permission.
Yep. HIPAA.
And you may be the one paying the bill.
They hide behind HIPAA. I had that happen with my father when he collapsed, and he was in ICU, could not speak for himself. And he had to have a quadruple bypass. And I was calling he was in Florida. I was calling from Atlanta, and they would not give me one piece of information because they just hid behind HIPAA and said, what's the PIN number? And I'm like, he's incapacitated. We had to get an attorney, sign a power of attorney. I had to get, three siblings. I had to get two of my siblings to sign the power of attorney and drive down there with it to be able to see him and make decisions on his behalf, because he was so incapacitated. He couldn't even make medical decisions. And so the doctors were in control of everything. And so that's one of those things. If I could add one point, when you said write down the questions, write down the answers too. because you have to know from visit to visit, from time to time, if you remember what those doctors are saying, if you're that organized, they're going to be that organized too. And so I saw earlier in the chat room, and shout out to Sherry Tampier. She has been on fire in the chat room. But I will say this, I know people talked about getting an attorney, and we're not even going to discuss that tonight. But you don't have any leg to stand on if you don't have all the information. So if you don't have the data in terms of what you've got going on and where you were, what your numbers are, you don't have a leg to stand on. You can't stand in court saying that person is a racist. You cannot prove that in open court. You need to have hard facts and hard data, and that means you got to write down your questions and write down your answers and be organized. And that's the only way if you're looking for any type of legal recourse. Go ahead, Doc. I'm sorry.
Yeah, no, that was great. That was great. I just will hit on one little point about the navigation piece. And I think part of that has to do with, I'll just focus here on, I've already talked about the hospitals and knowing your hospital.
Yes.
But the other piece has to do with, you need to know your health insurance plan.
Yeah.
If you have an HMO and you think you have a PPO, then you've got to know what plan you have and how to navigate your health insurance to make that work for you. I was today trying to get a blood test that I couldn't get to happen, and trying to make it happen by the 31st of December, because guess what? January 1st, I get a new deductible, rounding up in multiple figures. That's another thing you need to think about. You need to understand your health plan. Some health plans will give you money when you go and get a physical exam. It's part of those high deductible plans. So you've got to navigate. And if the doctor orders an x-ray for your grandmother and it's 15 miles down the road and there's a closer facility, you have to ask for that. That is navigating. It's helping to maneuver and be that person to smooth out the process. Because, back in the old days, we used to, when people were sick, they'd put them in the hospital and they'd work them up. They used to call it work up. They'd put them in. Dr. Lenore, you remember working up patients? They'd come in on Mondays. They'd miss all of work until Friday. You working them up. Well, what work you up at home now? So you're getting up today, going to the hospital after you've had nothing to eat or drink from the night before. Somebody's got to help figure that out, in particular for more senior people that may not remember all of the nuances of, well, you take this pill, but you don't take that pill. You need somebody there to help you with that.
And if you've got a chronic complaint and the doctor says to you, well, I can't find anything. Then you ask them, well, what were you thinking about before you decided you can't find anything? And how did you reach this conclusion? I mean, because otherwise you're not going to get any more attention. It's like it's your fault. And I can tell you that there's something this was in the New England Journal many years ago. And if you have a chronic problem like diabetes or heart disease, and you're difficult to control, then it sets up a relationship between you and your doctor. Now you get mad because you're not getting control, but the doctor gets mad because you're not getting well. And so pretty soon, you're shuffled off as, it's in your mind, or you're not doing what they tell you, and sometimes you're not. Sometimes you're not doing what they tell you. But you have to. But if you genuinely have a chronic symptom, and the doctor says to you, "Well, I can't find anything wrong," you say, "Well, what did you think about before you reached that conclusion?" To be sure that process was complete. One final thing, well, not necessarily final, because this case is just hugs at the heart of every Black doctor. It is an insult to all of us as Black people, but especially those of us in medicine, because we should be better able to make sure this does not ever happen again in any hospital in this country. But when somebody sends you to a specialist, you need to do a little of your own research, don't you, Dr. Noel?
Absolutely. You absolutely need to do a little research. I had a situation recently where a family member went to a specialist that was referred and got direction from the provider, and problem never really resolved, and that family member went out on their own and identified a different specialist. And had actually seen that specialist before, but you know, that thing, you just get busy, and you don't remember people's names. So the doctor just gives you a piece of paper and says, oh, go see Dr. So-and-so. You need to investigate the specialist. I often say to people, when you're having something like thyroid surgery, very delicate area, you want to ask that doctor, how many thyroidectomies, which means removal of the thyroid, many of these do you do in a year? So if his answer or her answer comes back, I do 6, well, you want to be under the hands of someone that does maybe 100. You want to get that information from that doctor. What? And then the other question, I had somebody call me the other day. Well, what kind of question should I ask this doctor that's doing robotic surgery? A family member again. I said, well, ask him about his or her complication rate. You know, patients forget, they feel that they're catatonic. They come in to see the doctor. Of course, they're sick. They have diseases. They're afraid. But you have rights as a patient. And in fact, that family member said, oh, my goodness, I never thought to ask that. Let me go and ask. I said, what's the complication rate and what are the complications? And, you know, how have they been resolved? An honest doctor who's not intimidated by questions will answer that. As Dr. Lenore said, I agree with him. When people start bringing in pens and paper, when people start asking me questions, I simply say, I got somebody that's really wanting to take charge of their health here. I don't see it as, oh, this is going to be a problem child. That you really, it's a partnership.
We're going to go back to
what's the name of the book? We're getting at questions asked.
Focus on your best health. Focus on your best health. And Dr. Lenore will have access to that for his listeners.
Yeah, on the website at aawellnessproject.org. That's aawellnessproject.org. Well, Dr. Noel, thank you so much for joining us, and stay with us. We're going to play we're going to get into our news of the week. You want to run that, and then we have some conversation about the coronavirus after that to close out our program.
Sure.
With the African American Wellness Project's Ethnic Health News Report, December 29th, 2020. While the coronavirus continues to rage across our country, today's numbers, 20 million Americans infected, 334,000 have died. Now there are 2 additional forms, easy to catch, but no more dangerous. Fortunately, the vaccine program has begun. 4 million Americans have been vaccinated, far fewer than expected. And I'm not certain who gets the vaccine has been decided. I only hope that African Americans most at risk are near the head of the line. Remember, though, after you get the vaccine, another shot may be required. And there are several weeks before you get full immunity. 70% of Americans will have to be vaccinated before we can all feel comfortable. Social distancing, washing your hands, and wearing a mask is still important. African American Ethnic Health News Report is sponsored by the African American Wellness Project, theblackdoctor.org. All right, so a couple of things that came up on the news this week. One is these mutant viruses. These are viruses. You expect viruses to mutate. That means that what happens is they get inside the cell and say, oh, no, this guy or this woman has got some protection here. I need to twerk things a little bit so I can ease past this. All right, so then what happens is that there are 2 viruses. But viruses are like trees. The branches may be different, but the trunks are the same. So that if you've got an antibody that attacks the trunk, then you can attack a lot of coronaviruses. And from what I hear, this particular virus, is more infectious. That means you're more likely to get it, but it's no more dangerous. The other thing is that people having reactions to the vaccine. I don't quite understand that as well as I should be, because as an allergist, I can tell you, generally you have to see an allergen before you react to it. So to have a reaction to a vaccine that you've never seen must mean one of 3 things. One is that you just don't do well with shots. I have a lot of people just pass out every time you give them a shot. Secondly, there's something in the vaccine that you're allergic to, and that's another problem. And there may be some people who have what we call non-allergic anaphylaxis. That means that the cell that causes anaphylaxis releases histamine. Histamine causes the vessels to swell, leak fluid, and airways to close down. Some chemicals will do that without having any immunologic situation involved. But you do have to watch for that. And because they didn't study that, then if you had major allergic reactions, you may want to wait on some of these vaccines. I think the final piece is this whole issue of herd immunity and how quickly things are going to get better. You know, first of all, you got to get 2 shots. You don't just get 1 for the vaccines that are out there. And then you won't be protected for 8 weeks after that. Now, if you're one of those people waiting for everybody else to get an immunization, you may have to wait years, because for smallpox, it took like 50 years for it to completely disappear. Yeah, it's important to remind you that if you may go to a concert or other places, and you may be less likely to have a problem, but if you do get the problem, you have the same problems that everybody else has. So I wouldn't count on herd immunity. I think you should, if you choose not to get the vaccine, which is certainly your choice, you need a different survival strategy. Were there any questions left over that you think we need to deal with today?
Yeah, there was one question I wanted to address it in a holistic sense, but there was a mother, and she was talking about her child having sickle cell, and how do you deal with that? Because a lot of sickle cell patients present to emergency room, especially for pain management, and so one of those things are have a binder, and have everything every time they've been in there, all the medications they've been giving, who the doctors have all of their information in there. And so when you present with your child, you hand that to the nurse, you hand that binder to the physician, and so you don't look like you're just drug seeking for your child, and you can pick up at that point. So you don't have to give them the entire verbal history. You can hand it to them. Everything's in that binder. And so you can really kind of save yourself some time and get your child treated as quickly as possible, or yourself, if you're an adult, or yourself treated as quickly as possible. Also want to say that on blackdoctor.org, if you go to our website, there are a number of conditions, and it's about how those conditions affect Black people and how it affects you and how you can get treatment, how the proper way to go get treatment. There's a number of treatment conditions on there. Go to the site, go to the African American Wellness Project. If you don't have a Black doctor that you're seeing, you can get the information that you need to learn how different illnesses affect Black people, so you can be armed with the information going into seeing a physician. I'm off my soapbox.
Well, all those that's excellent information. And I think because Dr. Moore so represents what we're all about, that we'll mention something about almost every program.
Yeah.
There was a time when I said, you know, what we need to do is at the African American Wellness Project is to get a little button with an eye on it that says, we're watching you. So when you go to the emergency room, you throw your button so you know that you're part of a community. I'd like to thank Dr. Glenda Newell Harris for taking time to talk about this very important topic. We had planned to talk about some of the stories for this year, mostly all COVID, but we thought this was so very important, and we're so passionate about it, so close to us as Black doctors, that it defines what Black Doctor Speak is all about. Yeah. So I thank you, Mr. Ellis, Mr. Dean, for putting this together, and I want you to remember health is your biggest asset, so protect it. We'll talk again next week.
Thank you.